So if you hear us like bicker a little bit like an old couple, you all that are in healthcare know exactly what I'm talking about. So you'll understand. So without further ado, before we jump into the actual case study, I did just want to go through, just to level set, a quick refresher on sepsis and sepsis guidelines. Severe sepsis adds acute organ dysfunction secondary to the infection, and septic shock is severe sepsis plus hypotension that is refractory to IV fluids, often needing vasopressors to maintain a MAP of greater than 65 with a lactate above 2. Sepsis 2, in use since 1992, with the surviving sepsis campaign later adding lab value specificity. There's Sepsis 3 since 2016 that reframes sepsis around life-threatening organ dysfunction rather than SIRS, and introduces SOFA and the bedside Q-SOFA screen, and which framework your organization uses affects diagnosis and documentation. So since 1992, the definition has rested on infection plus features of SIRS. The diagnostic threshold is 2 or more criteria attributed to an infectious cause that cannot be easily explained by another coexisting condition. Those criteria fall into 4 categories for sepsis 2: general, inflammatory, hemodynamic, organ dysfunction, and tissue perfusion. The surviving sepsis campaign added specificity around diagnostic lab values, as we'll see, like CRP, procal. Inflammatory parameters include a white count over 12 or less than 4, or more than 10% bands, which is those little neutrophils, plus an elevated CRP and procal. So 2 or more respiratory rate, at least 22 altered mentation, or systolic BP at most 100. And septic shock now requires vasopressors for a MAP of at least 65 plus lactate over 2 despite adequate fluids. And then the surviving sepsis campaign, and then 2016, finally, sepsis 3. First, the 2024 Phoenix criteria bring the organ dysfunction model to children, replacing the pediatric SIRS approach. The second is that the proposed ICD-10-CM revisions would restructure the A41 and R65 codes and retire R60 for severe sepsis. So we know when the patient comes in and they are flagged for sepsis, they need to, get those 2 fluid boluses, of course, if it's appropriate for the patient, if they're not in CHF or what have you. So we have a 71-year-old male with a history of prior osteomyelitis and recurrent right foot infections requiring multiple amputations, presents with 1 week of generalized weakness and malaise. In the ED, the provider also documents the patient has fever with a temp max of 101.7, leukocytosis, markedly elevated inflammatory markers, normal lactate, mild acute kidney injury, tachypnea, and an O2 sat of 95 to 100% on 2 liters nasal cannula. It's a good opportunity to link an organ dysfunction if there is any on the patient, because linking sepsis with an organ dysfunction when we're using sepsis 2 criteria really helps strengthen that diagnosis. But in any case, we would need to send a query to clarify, because it's only saying that there was a concern for sepsis in the ED, and then it drops off in the H&P. Also, as they mentioned in the ED, the patient had a temp of with a max temp of 101.7. Respiratory rate was 13 to 20, which actually does not meet the 2 out of 4 SIRS criteria. However, if we go and look at the labs, we can see that the PaCO2 was 28, which is less than 32. So for the SIRS criteria, they actually have to be either greater than 12 or less than 4 or 10% bands. So now that I have confirmed that we have, just the basic SIRS criteria plus 1 actually inflammatory parameter from sepsis 2. If we're sending out a query to link that organ dysfunction, which we will need to, we can't just assume because it's documented that patient is meeting criteria for AKI. So if we have a creatinine level within 30 days, and don't quote me on that, I'd have to go back and look. Then we do have a definitive baseline. So we go back in and look, and we see that patient's creatinine on 6/15/26 was 0.85. So if we multiply that baseline by 1.5, we know that they are meeting criteria with creatinine this emission of 1.34. Because that's greater than 1.5 times the baseline. So yes, we have confirmed the patient definitely has meeting criteria for AKI and has that organ dysfunction parameter met. But when the O2 sat 95 to 100% on 2 liters with tachypnea, a normal respiratory rate, that's one of those gray area situations. But as long as you're making sure that you have all of the information in there, you have your treatment, you have your indicators, compliant question. As long as it's a compliant query, how you set it up doesn't matter, but I like to do it in order. This is a 71-year-old male with a past medical history of diabetes, prior osteomyelitis, and recurrent right foot infections requiring multiple amputations, presented with 1 week of generalized weakness and malaise. So here, like in the ED, it was stated, and always cite your clinical indicators and quote anything that you're taking from the charts. We also want to show that it was stated there was a fever, leukocytosis, marked elevated inflammatory markers. Like, you want to show that neutrophil count was 92%, because that shows that they then meet that threshold. So that they are technically meeting that organ dysfunction for respiratory failure threshold. Severe sepsis with AKI, sepsis without acute organ dysfunction, please clarify etiology of AKI, severe sepsis with acute hypoxic respiratory failure and AKI, or all of the above. And the reason why is the patient, we want to give these response options: severe sepsis with AKI, severe sepsis without acute organ dysfunction. Please provide etiology of AKI. Instead, it's in case the doctor is thinking maybe the AKI is due to dehydration and not related to the sepsis, because we never want to lead a doctor to a specific answer. Or then the other response option could be severe sepsis with acute hypoxic respiratory failure and AKI, since they do meet that criteria. Again, people do it differently, but this is how I like to give and link that organ dysfunction with sepsis when I can. So, but we'll see, I'll put another poll out there to see what else would be interesting or what you would like to see for a case review. If you want to email me, I know we didn't have a lot of time, but feel free to email me at Carrie@thequerycorner.com.